welcome back. Today is going to be probably my favorite topic because it has to do with what we went through. Basically, if a lesbian couple comes in to fertility clinic and says, we want to have a family, we have no known or past fertility issues, what do you recommend? ICI, IUI, IVF, reciprocal IVF? Take it away and introduce yourself again.
Yep. Hi, everyone. I'm Jenny Nichols, Dr. Jenny Nichols with Sincera Reproductive Medicine. And I think the biggest thing is we've kind of already talked about it. The first thing is doing the testing and making sure everything is okay. So when we do that testing, we want to make sure that tubes are open, uterus is normal. We know sperm is going to be normal. Why? Because we're getting sperm from the sperm bank. Unless you're using a known donor, and then if there is a sperm factor or a major sperm factor, then number one, do you want to use that sperm? Or if there is a major sperm factor because you're using a known donor, does that push you towards something like IVF because there's a big sperm factor? But you're going to assume that sperm is normal. But if tubes are blocked, then that's pushing you towards one treatment or another. But assuming everything is normal, ovaries are functioning well, tubes are open, uterus is normal, there's no fibroids or anything, then the likelihood is a couple is going to conceive really well. You know, that woman's going to conceive really well no matter what you do. And so something I'm going to tell a couple is you're not an infertility couple. You're not coming in struggling to get pregnant for over a year if you're less than 35, for the last 6 months, if you're 35 or older. You're not infertility. And so that's something you have on your side. But that doesn't mean that you might not struggle after a period of time. But the question becomes is what are you going to do? The hard part is we can't predict after a period of time if you've been trying, are you going to be that woman who does struggle? And do we need to move on to the more aggressive, or do you get pregnant on that first IUI? And so one of my favorite sayings is, it doesn't mean that if you're 25 and you come into my office that you couldn't do IVF the very first month. And I couldn't say, hey, if you do IVF the very first month, you have a higher chance of getting pregnant, or you could do an IUI and here's your chance. It just means what are the statistics? And as long as someone sets out for you, hey, what are your chances of getting pregnant based on how your ovaries are functioning, what are your age, then you very clearly can say, I know what my statistics are and what are my choices and what am I going to choose to do? And I think that's, something that anyone should kind of say, yeah, I get what my chances are and I'm going to make my choice. I can say, hey, I'm going to use my natural cycle. I'm going to make my one egg and I'm going to try with an insemination. A lot of the time, the ICI, we're doing inseminations. By the time you're in our office, we're going to take the sperm and put it into the uterus, the Intra Uterine Insemination, because it's what we're doing. We're going to take that washed sperm and put it into the uterus versus the cervical, because it's what we do as the docs. We're going to be able to know that we're putting it up into the uterus. We're triggering once we see that egg, and we know we can put it up into that uterus and bump up the chances of getting pregnant. Now, when you're ordering the sperm, they have that ICI, the IUI, and then the ART ready, the IVF ready samples. And all you're getting is sperm that has higher concentrations going to lower concentrations of, the chance of conceiving based on how close it's getting to the egg. And I saw a great, on the website, a great article. Yeah, I was perusing the website. So a great article that shows, how many sperm are needed based on where it is. If you're taking the sperm and laying it right on top of the eggs, then you clearly need less sperm. If you're taking the sperm, like in intercourse, if a couple is trying to conceive with intercourse, a heterosexual couple, then it's down in the vagina. It clearly needs to swim up the vagina. Where's my uterus model? It clearly needs to swim. If a heterosexual couple's having intercourse, it needs to swim up the vagina, up the cervix, up the uterus, down the tube, and to that egg. So if it's an ICI ready, then it has a lot further distance to go. So in the long and the short of it, When you're looking at ordering sperm, that's all that those different abbreviations mean. So what are we going to talk to a couple about? As long as everything looks good, tubes are open, ovaries look good, then I can say if you're less than 35, there's nothing saying that you can't try basic inseminations. Why? Because the ovaries are functioning well, the tubes are open, and by doing an insemination in a less than 35-year-old woman, the chance of getting pregnant should be pretty good. Now, when I say pretty good, does that mean 100%? No. Per cycle? No. Does it mean 50%? No, it means about 20 to 25% in a cycle. And that means setting your expectations realistically. That means I'm not going to likely get pregnant. And I mean, really, there's a higher chance of not getting pregnant in that first cycle than getting pregnant. So it means if we watch a woman's ovary make an egg, and what we do is we give a trigger shot medicine to know that she's going to release that egg. Sometimes we do give a medicine if she doesn't get regular periods, or even to help bump up the chances a little bit, like Clomid or Letrozole, to help her make an egg on a timely basis, or maybe even based on age, make more than one egg, Clomid or Letrozole. So we watch her make an egg, or sometimes 2 eggs. And so as she makes that egg, we give her a shot medicine so that we time that insemination. So once she gets that shot, we know she's going to ovulate, and then we time the insemination based on when she gets that shot. And the timing of that insemination, usually we time that insemination 24 to 36 hours later. And so the key of that is then we know exactly when to do that insemination. It's not, hey, you might ovulate around this time. It's no, you're going to ovulate right here. And so then the insemination is done at a key point prior to or right as she's ovulating. And then the insemination, they thaw the sperm, they take a teeny little catheter, put it into the uterus, and put the sperm right up in the uterus so that we know then the sperm can swim down the fallopian tubes. I say sperm aren't so smart, and some stay in there, some come back down, and they hopefully get to where that egg is. And not all the sperm are going to get to that egg, and they may not fertilize it. And even if they do, that embryo may not grow and divide. And it's why that chance of success is not that high. Even if it does fertilize it, that embryo may not grow and divide. And even if it does grow and divide, it may not make it to the uterus, and it may not implant. So even in a young, less than 35-year-old woman, she may not be pregnant that first month. And so usually as you're ordering sperm, we say, order usually more than one sample, because that shipping is the costly component of it, or a costly component of it. It's not the highest cost by all means, but a costly component, so that you have more than one sample. So if you're not pregnant, you can plan on doing another cycle. And, in a young, healthy woman, that you can say, hey, do I plan on doing 2, 3, maybe max of 4 cycles of these inseminations to try to get pregnant? Why? Because if I just said a chance of success of maybe 20, 25%, maybe I'm trying 3 or 4 cycles of that. Now, if you're not pregnant after those 4 cycles, that's where we say, hey, do we try something more aggressive? It doesn't mean that a young 25-year-old woman who has never conceived before couldn't come into our office and say, I don't want to do an IUIs. I want to go right to IVF. Clearly, her best chance of getting pregnant is IVF. And that chance of success with IVF in a young, healthy woman statistically is about 50 to 60%, clearly higher than that 20 to 25%. And there's nothing saying she can't do IVF. It's not what she necessarily needs to get pregnant. Why? Because when a woman does IVF, and we'll talk more about IVF in the future, and we can talk more about IUI in the future, but IVF, we can stimulate a woman's ovaries to make as many eggs as she can. While she's asleep, we take those eggs out of her through a small needle in the vagina. The eggs are in the dish. We mix them with the sperm. We watch them grow and divide, and then we take the best looking embryo and put it back into the uterus. So we know that we have the eggs, we know we have an embryo that fertilizes, we know it's growing and dividing, and we know it makes it to the uterus. So it takes out the question marks of everything that was happening inside of the body. So the question becomes is, do you need IVF? No. Can you do IVF? Yes. And it's just a matter of then, are there any other factors that may bump you towards IVF sooner, or, how comfortable do you feel with what your decision is?
Right, right. So if a couple comes in and they are both under 35 and they're like, okay, we both want to get pregnant, do you typically say the older one should go first?
Yeah, so definitely if she's older and we know she wants to conceive or use her eggs, yes, because her ovaries are more on a timeline than her partner's. And then we haven't even touched on the fact of reciprocal IVF, or the fact that both partners of the couple have ovaries and uterus. And so you can say, hey, what do you guys want to do as a couple? Do you want to use one's ovaries and the other's uterus? Do you want to both conceive? Do you want to both conceive at the same time? Do you want to do one first and then the other? Anything. Besides raising two babies at once seems crazy. Otherwise, anything's an option. I think we've talked about this before, but, roadblocks come in the way. So you can say, hey, this is our plan, and this partner first, and then you find out, hey, there's a cyst, there's a fibroid, and then this partner says, okay, maybe me. Or, hey, my uterus might not be able to carry, and this partner says, hey, my uterus can, but my ovaries may be, used for my uterus. So, we've talked about before, keep an open mind. But I think the answer is, there's nothing saying that an IUI can't be the starting point. There's nothing saying that if you want reciprocal IVF, that you have to consider an IUI, that then IVF is obviously the treatment, because you're saying, hey, if you want one partner's eggs and the other partner's uterus, then clearly you need to be doing IVF.
Right. That's exactly what we did. Jordana's eggs in my uterus. And interestingly enough, different ages at different retrievals, since we had to go through more than one. So in terms of IUI, you said that it's like 20 to 25% chance if you're under 35. What is it when you're over 35? I know it changes at different.
So over 35, usually it's about 15 to 20%. And then, at 40, usually we're saying, about a 5 to 10%. So it definitely starts declining. And obviously all of that fluctuates based on how a woman's ovaries are functioning, based purely on not only her age, but on how her ovaries are functioning based on her test levels. So her anti-Müllerian hormone and her FSH. So, it's really hard, because that's where you have to rely on what your doctor is counseling you on, of how your ovaries look like they're functioning, and your guidance of your doc of saying, hey, your ovaries don't look like they're functioning as well as they should be based on your age, and saying, hey, maybe we look at becoming more aggressive sooner. And the counseling of, do we talk about, a more aggressive treatment sooner?
Yeah, when you have two uteri.
Yep.
and lots of ovaries, there are so many options when you have that. So you said that 50 to 60% chance with IVF if you're under 35. What is it when you're 35 to 40?
Yep. Usually we say about 40%, 40 to 50%, depending how the ovaries are functioning. And then at 40, it's about 20%.
Oh, okay.
Okay. And then usually the key marker is at 45. Usually we're counseling a woman that using her own ovaries is usually not even an option, just because the chance of success drops off so significantly. And unfortunately, the chance of miscarriage goes up so significantly, purely based on egg quality, that at that point, you start talking about donor egg.
Right. But the uterus is totally cool.
The uterus, as long as there's no fibroids in there. Yeah. The uterus can carry. Usually our cutoff then becomes at 50, only because of increased risk of health risks and complications.
Got it.
So it doesn't mean it can't. It's just that, other complications start coming into play.
Right. Well, the one statistic we didn't cover is just ICI. So if you just straight up insemination into the cervix, what are the odds of getting pregnant?
Yeah. So as a practice, we don't do into the cervix. So I won't give you those statistics, but I'm sure that the sperm banks can.
Got it. I know it's less than
less
than the other ones.
Yeah. Yeah.
Got it. All right. So we're really just looking at age, egg health, ovary health, whatever. So it's really just, okay, let's come in, let's get you both tested if you're both under 35, and, just get you both tested and then kind of go from there and say, hey, you're
Yeah.
both 30, but your levels are not as good as this one. So maybe we start with your eggs, kind of a thing.
Yeah.
All right. Well, great. Lots of options, lots of things for people to consider and talk about. And, it's so cool. I didn't know about reciprocal IVF before. And I mean, it makes sense. It's literally surrogacy, like what has been happening
Yeah.
for so long, but I never thought of it. And it's such a cool option that is now very much in the spotlight of
And I think
options.
some couples come in, and I think, as a fertility doc, you have to go into an appointment with, a same-sex female couple saying, hey, what do you guys think? Because some partners say, oh my gosh, I never want to be pregnant. I never want to use my eggs. I never want to go through this. And some couples say, oh my gosh, yes, but I never want to carry, or oh my God, like, yes, we want to do this and then this and then this and then this, and like have in their mind like exactly what they want to do and have thought about all of it. And so I think you just have to remember that it's my job to be able to give them or make sure they know all of those options. And that's the coolest thing about, being able to have a platform like this to say, and have you have this on a online site to say, hey, there's this option and this option and this option and this option, so that people can get that information that maybe they wouldn't have normally.
Yeah, yeah. I mean, it's good to just know what you can do, and I think that
Yeah.
that's what we learned through Instagram about reciprocal IVF.
Yeah.
So it's great to just have the information to make that educated decision, but really ultimately knowing that when you go in there, you need to get that testing done first to just make sure that
Yeah.
everything is functioning well, because you don't know. And
Yeah.
for us, we had one plan and it ended up being something completely different, and roadblocks and bumps and all of that.
Yeah.
But and that's why I also shared, when talking about fertility clinics, and you're really, the couple is really interviewing the doctor as well, because this is a very intimate and emotional journey that I remember crying to you so many times on the phone.
Yeah.
Just
Yeah.
like, hey, you need surgery. Like, hey, you're not
Yeah.
pregnant. And
Yep.
it's hard. So it's,
And I
you want
tell
to make
people
sure
it's a
that,
roller coaster, like that 25% chance of success. You almost have to be prepared for it to be a negative test. And remember that there's a higher chance that it's not going to be positive that first time,
yeah,
versus it's really hard to remember that. Like you think, oh my gosh, I had an egg. And yes, we just put sperm in there. Why am I not going to be pregnant? I should be pregnant. There was an egg, there was sperm, I'm going to be pregnant. But if you instead have this attitude of, hey, it's going to be a higher chance that it may not work. And if you're pregnant, you're like, this is awesome, it worked. Because otherwise you're at the top of the roller coaster, and that roller coaster is coming down and you're like, yes, this is going to work, I'm going to be going right back up and I'm going to be positive. But you have to be ready for that bottom of the hill and be like, oh my gosh, I have to be ready to accept the fact that I'm going to be going down to that bottom of that hill, because otherwise it's just a nasty roller coaster that you're just not ready for it. And
yeah,
fertility is a roller coaster, and you just have to be ready to kind of prepare yourself for those ups and those downs. No
yeah,
question.
yeah. No, I'm the crazy one. I thought I was pregnant every time. I was like, I felt it. I totally emailed you. I'm like, I felt it. There's two.
Yeah. Yeah.
Jenna's emailing me again. It's like, I swear, it's a lot. It's hard.
Yeah.
It's hard. And a lot of couples who come to you have been trying for so long, and it's,
Yeah.
yeah. So it is about
I
finding
think that's
the
another
best.
thing, is I think as a heterosexual couple, people have been trying at home naturally for a year. And so by the time they come to see us, they're like, okay, something's totally wrong. As a same-sex couple, you come in and you're like, nothing's wrong with us, we shouldn't be getting pregnant, we just need sperm in there, like everything's totally fine. So when something comes up and there's maybe something not right with the uterus or the tubes, or the ovaries, it's like a blow of like, what do you mean something's wrong? Like, I thought this was going to be easy. So I think you have to kind of be prepared of, maybe not everything is right, and let's do the testing just to make sure, and then take it from there.
Right. Right. And I always say, like, remain positive for sure. You know, you don't want
Yeah.
to be down and putting that on all energy on you, but also
Yeah.
just, again, being realistic and knowing the stats of
Yeah.
possibilities. So,
Yep. Agree.
all right. All right. Well, thank you
Awesome.
for sharing that information so that people can kind
Have
of
a good day,
see their
everyone.
options. All right.